Hello, this is Stephen Harrison, and you're listening to Surfing the NASH Tsunami in the New Pod City Podcast Network.
Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, C-suite veteran Peter Traber, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on this week's edition of Surfing the NASH Tsunami.
For everyone with an interest in NASH, or more broadly, fatty liver disease, surf's up. Episode 13 of Surfing the NASH Tsunami starts now. Hey, we're officially teenagers. Thanks to those of you who listened to last week's discussion of the Intercept Complete Response Letter and what it means for the future. Most listened to episode we've had so far. We didn't get questions. We got lots of comments. I'll chat about that in a minute. Peter Traber is not with us this week, but Stephen and I will be joined by our usual surf buddies, Louise Campbell and Sunil Hausmain. And I want to remind you, we're still getting organized for the new patient segment. So we're looking for questions to the webpage or emailing questions to questions@surfingnash.com. Other than that, time to get started. So let's start with professional highlights this week. Brave one, go first.
I can go with a professional highlight of the week. We've got confirmation. We're somewhere around about the 1st of August. We're about to start scanning in a major post-COVID study, which is a great piece of news for us and an extensive part of adding diagnostics for liver and whether or not could have been involved in a COVID response for the patients. Obviously, it's a long study, but it's certainly a good piece of news for us. So that's my highlight of the week.
That's very exciting. Sunil?
A big milestone was kind of internally within the company. We had a number of different ongoing R&D activities, and we finally took the time in this COVID era to sit down to kind of go through, strategically review a number of those activities. And now we have a lot more clarity moving on for the rest of the year in terms of some of the programs we'll be funding and pursuing. So pretty exciting.
I'm going to shift gears and do a personal highlight because coming off the 4th of July weekend, I went against conventional protocol, if you will, and we had a mini family reunion out in the middle of Central Texas, away from COVID Central here in San Antonio, but great time being able to get together with my parents and siblings and their children over the 4th of July and watch fireworks and celebrate our independence, which is near and dear to my heart. And it was a special time for sure. So that trumps everything else I would have to say. And so that's what I'm going to highlight this week.
For me, I think it's probably the tremendous response to the podcast last week. We had comments come in from physicians, from industry people, from advocates. We are talking now about having co-sponsors for a regular or semi-regular patient segment. More on that in the next 2 or 3 weeks as it starts to take formal shape. But it's exciting and it's a lot of momentum and it's really good stuff. So with that done, let's move on. So about last week, as I mentioned, no questions, several comments. Perspectives broke into two camps, kind of like they did last week, which was some people thinking that this might be the end of accelerated approval for NASH drugs in the U.S., and that would be a good thing. And others suggesting that for accelerated approval to work, you needed a clear risk-reward benefit around safety and efficacy. And maybe, for whatever reason, FDA did not believe that obeticholic acid reached that level. The one consensus from everyone I spoke with was that it was a shame, as Brian said last week, how the FDA had dealt with Intercept, given how transparent and obliging and really good Intercept had been as a company throughout its dealings with the agency. What this has done is led us to think that we want to spend the next few episodes talking about issues that will help drug developers and also drug regulators make sense more quickly of what really great agents are versus marginal agents. Along the way, I think spending some time talking about the issue of accelerated approval, but that won't be the primary focus. So where we're going to start is where we said we would start last week, which is unusual. Last week, I mentioned a private investor who had asked about novel technology and thinking around diagnostics. And this week, in an episode we're going to call D-Cubed, or Diagnosing Diagnostics 3, we're going to focus on 3 areas where the technology of diagnostics can get better and what it will mean as it does so. Number 1, drug tests that can predict, define, or stage diseases. Number 2, artificial intelligence and machine learning and what that can do to improve our precision or what we're looking at. And number 3 is in-office devices with low capital expenses and ease of use that will measure NASH or calibrate parts of the NASH score, fibrosis, steatosis, with the kind of accuracy that we expect from larger, more expensive pieces of equipment. One thing that complicates when we talk about outcomes, as we've said throughout the podcast, is that the outcome you're looking for may depend on where the patient is in the stage of disease. So that if you're in F3, advanced fibrosis, or maybe early cirrhosis, the key outcome is stopping the progression of liver disease so the patient does not progress through cirrhosis to either long, slow, painful death or liver cancer or need for transplant. A little earlier in the stage of the disease, maybe F3, certainly F2, maybe F1. The major issue is cardiovascular, because cardiovascular is the major cause of death for NASH patients. So the outcomes that you'd be looking for are drugs that had an impact directly and indirectly on improving cardiovascular health. And if you go all the way back into NAFLD, the issue may be around viral response, based on some of the studies that we've mentioned here that have to do with the relationship between NAFLD and response to the COVID-19 in a couple of settings. So what we're going to do today, with that kind of triad of outcomes in mind, is each of us will address one of the three key issues I described, and we'll ask questions throughout. Louise is going to ask questions from two perspectives, as patient advocate and as someone who administers significant amounts of testing and FibroScan through Towers Health. So first, let me turn to Stephen. And Stephen, why don't you kick us off by talking about blood tests and what more we can learn from blood tests that are coming online or that will be used differently over time as they are now.
Thanks, Roger. So this context of non-invasive diagnosis of liver disease patients with advanced fibrosis is not novel. It's not new. It's been around for a while. We know that the imperfect gold standard, if you will, liver biopsy is not ideal for a lot of reasons. We've talked about that before. It's well known to everyone. So we've got to get away from liver biopsies that are risky, that have inter and intra-observer variability issues, into something that's more plausible and acceptable for our patients. What we're talking about is the context of use of identifying NASH with moderate to advanced fibrosis. And the next question you have to ask, if that's who you're looking for, is who's the at-risk patient? If we just apply this across the board to everybody that walks in off the street to a primary care clinic, we'll get widely disparate results when we apply the non-invasive testing strategies that we have compared to we're measuring this in a high-risk population that has been well documented to have a high prevalence of NASH. Once we know who those high-risk patients are, then we can identify the high-risk patients with moderate to advanced disease. So having said that, the rest of my little section here is going to be focused on people that we perceive to be at higher risk clinically. And ideally, that would be a diabetic or even an obese diabetic, because that's really the low-hanging fruit. That's the population that has lots of fatty liver, and they're enriched for non-alcoholic steatohepatitis and advanced liver disease. Historically, we've been able to use blood-based biomarkers, and ALT and AST have been around for decades. Alanine aminotransferase and aspartate aminotransferase. Very simple chemistries that you can obtain in any basic lab. You can even do CLIA wave testing with a Piccolo device that's transportable and can be taken out into the community. And it gives us a very simple valuation. Where we have studied this in the context of NASH with advanced fibrosis is looking at what the AST is relative to the ALT. We call this the AST-ALT ratio. And when that valuation is 0.8 to 1, that puts the patient at significantly high risk for having advanced fibrosis. In fact, some studies suggest the odds ratio is 9 for advanced liver disease, just looking at that ratio. That's one simple test that you can do in your clinic. An example would be you have an AST of 60, an ALT of 60, that ratio is 1. That patient, by its own right, is at high risk for having moderate to advanced disease. Other newer studies have come along that have combined demographic information with biochemical information with the idea that they're going to improve either the sensitivity or the specificity, and then vicariously the negative predictive value or the positive predictive value or the overall accuracy of the test. I studied something a long time ago called the BARD score. And this is built off univariate analysis where we showed that BMI over 28, AST-ALT ratio greater than or equal to 0.8, and the presence of diabetes all were independently predictive of that NASH patient with advanced liver disease. And then we put it in a multivariate model and applied a weighted sum where the AST-ALT ratio actually was weighted 2 points, BMI 1 point, diabetes 1 point. And if you had 2 or more points, you had a positive BARD score. Turns out it worked very well if you were Caucasian and lived in the central Midwest part of the U.S. and you were obese, and it carried a very high negative predictive value for excluding people with advanced disease. Simultaneously to this, the NAFLD fibrosis score was being developed by Paul Angulo at the Mayo Clinic, and he found better sensitivity and similar specificity to the BARD score. And then subsequent to that, the Fib4 test came along, which combines AST again with a couple other clinical variables, originally developed in HIV, Hep C co-infection, and then applied more across the board to non-alcoholic fatty liver. All those tests I just mentioned are very, very good for their negative predictive value, but they lack positive predictive value unless you're studying a very enriched population. Usually we see this in tertiary care referral centers where people are referred with suspicion for advanced liver disease. If you do liver biopsies, the cohort of patients seen in this population is enriched for F3 and F4 disease. But when you apply those 4 tests, the AST-ALT ratio, the BARD, the NAFLD fibrosis score, and Fib4, to a general population, you tend to get very low positive predictive values. So newer things were developed, newer blood tests were developed. You have the Fibrometer, the FibroSure, all these are proprietary algorithms that combine multiple different variables. In fact, Fibrometer version 2 has 8 different variables, I believe, including platelet count, age, sex, hyaluronic acid, urea, AST, alpha-2 macroglobulin, etc. Very complicated algorithms. They're proprietary. They're blood tests. You draw blood, you send it off, you pay a fee, you get a result back. Turns out they're not much better than the simple blood tests that we have. And so most of us tend not to use them because they're quite expensive and they don't provide a ton more utility than what I've already mentioned. More recently, there's been interest looking at something that can give us a better idea about the fibrosis content inside a liver. And to that end, the ELF test was developed, which combines 3 measures of extracellular matrix proteins, hyaluronic acid, procollagen 3, N-terminal peptide, or P3MP, and TIMP1. Values greater than roughly 9.8 to 10.5 were consistent with a diagnosis of advanced fibrosis. And then ProC3, which is kind of a cousin of procollagen 3, N-terminal peptide, but it's the neoepitope of that. And that has also been now linked to fibrosis, particularly fibrogenesis. And values of around 15 to 16 have been identified to link a patient to advanced liver disease. Now, both of those markers of fibrosis are still under development for the context of use as a diagnostic, but those are the numbers that have been tossed around, 9.8 to 10.5 for an ELF test. It is proprietary. It does cost to send that one off and get a result back. And then ProC3, which is also proprietary, and I don't think is actually ready for prime time in the clinic. We use it in the research field all the time. And then more recently, and I'll wrap up with this one, there is a new kid on the block. It is, again, a combination of variables, and it's called the Ns4 test. In this particular vein, again, we're combining a group of 4 different clinical variables that can tell us about the diagnosis of NASH, particularly a NAFLD activity score of 4 or more with F2 to F3 fibrosis, ideally greater than F2, so it would include potentially some F4s as well. And this test, like and I didn't mention this before, but like the NAFLD fibrosis score and the Fib4, is broken into 2 different variables, 2 different valuations, one with a high sensitivity and one with a high specificity. But ultimately, that test is still needing to be validated in a couple different data sets. It was derived and validated in-house through studies that GenFit had been doing, and it compared actually very favorably to other tests such as the Fib4 NAFLD fibrosis score, ELF, and Fibrometer. All of those that I mentioned, the Ns4 test outperformed them. There were area under receiver operator characteristic curves of 0.8 for Ns4 compared to 0.7 for Fib4, 0.6 for NAFLD fibrosis score, and 0.7 for ELF, and 0.68 for Fibrometer. So it does have good diagnostic performance, but it needs just to be validated outside of the original data sets. And with that, I'll turn it back over to you, Roger.
Stephen, what are the issues specifically you think we can resolve reasonably completely using these kinds of tests, and where do you think we will not get the information that we need to be clear either on diagnosis or evaluating drugs working how well?
Well, we need large data sets to answer those questions. And one of the areas there are a couple different areas where we can get that data. The first one is through large independent consortia that have been set up and funded by industry, but through an agnostic channel. And what I mean by that is basically there's an IMI funded initiative called Litmus, which is mainly based in Europe. And there's a US funded consortium called Nimble that has NIH funding attached to it. And both of these entities were established to identify non-invasive testing strategies, not just blood-based or wet biomarkers, but also imaging biomarkers, and then potentially the combination of wet biomarkers plus imaging. But those two entities were set up to study literally several hundred to thousands of patients to analyze in a very agnostic manner these non-invasive testing platforms that I've mentioned, particularly the NAFLD fibrosis score, Fib4, ELF test, ProC3, and now Ns4 is certainly being analyzed, I believe, in Litmus, and I'm not sure about Nimble. But that's one way that you could get at this answer as far as a validation. The other one is focusing on large phase 3 trials or very large phase 2B trials where pharmaceutical industry is actually measuring these non-invasive tests as either secondary or exploratory endpoints as part of their large paired liver biopsy clinical trials. And while it's not a primary endpoint, this data is being analyzed alongside the biopsy for its correlation coefficient, for its accuracy as it's able to predict the presence of NASH with advanced disease. We've generated some data. We've seen large data sets from Gilead come out, giving us the data with ELF that I've mentioned, where we found the score of 9.8 predicting advanced liver disease. They've also shown that a score greater than 11.3, different context of use, but is associated with progression to decompensating liver disease. So these pharmaceutical large data sets are very helpful and instructive. Ideally, we need more of them, and we need other companies to validate what one company shows. So at the end of the day, it's all about numbers and generating enough data to substantiate the claim that's been made.
Louise?
I think from a perspective of how patients view this, or how we can certainly see how the timeline's gone, and I think Stephen's absolutely correct. AST and ALT has been around for a long time, and the abnormalities in that. But if we look back, in 1950, cirrhosis was noted in diabetics. We are now 70 years on in that timeline, and we are still discussing the poor diagnosis of patients with fatty liver disease. The predominant ones, as Stephen repeatedly says, are the low-hanging fruit, which is diabetes. But if I go and look at the British Liver Trust survey from last year, that was one of the largest surveys ever carried out in the UK, only 4% of patients being diagnosed in a GP surgery are those who are being picked up with lifestyle conditions. So that's our diabetes, that's our cardiovascular disease. So in those 70 years since we detected that cirrhosis was noted in diabetes, and despite the mortality rate of diabetics increasing due to liver disease or renal failure, and hypertension and all of the other comorbid, we've not got any better at it. And all of these blood tests have been around and available, but we are left with exactly the same discussion from several weeks ago. And we're desperately trying to find blood markers in an organ that doesn't show distress. And when we're looking for conditions in liquid biopsies, we're looking for the condition itself. So we're looking for a tumor. Liquid biopsies obviously very well tried in hepatocellular carcinoma. So we're actually looking for the other condition to give us a symbol and a sign so that we can desperately find it. Despite having all of these tests available, and despite having great outcomes for some of these tests, Fib4, if used in primary care very well, can actually reduce significant referrals to secondary care. But actually, we're still looking for abnormal tests. And as we know, about 70% of patients with abnormal livers will have normal liver biochemistry. So it is about getting better, but it is about asking the question in the first place, because an awful lot of people have gone through medical, nursing, nutrition, dietetics, training in that 70 years. But I regularly hear from GPs, when I look at Twitter, when I look at these nutritional forums, that they do not get nutritional input into their training. They're not looking for a disease, as we know, affects 1 in 4 of the global population. And Stephen's right, a lot of these blood biomarkers only target the patients whose ethnicity is Caucasian. If you look at Asia, PARS will have a different definition for NAFLD and NASH on their BMI. Their BMI is less. We know that Hispanics have a different rate. So there's a lot of ethnicity profiling that needs to be done so that all of these testing systems actually take into account the genetics of patients. When I was treating hepatitis C, our Arabic population reacted very differently, and sub-Saharan population reacted very differently to interferon to a lot of Caucasians. So you have to take that into account when you were treating them. Everybody's an individual. Patients want to be treated as individuals. Blood biomarkers, yes, but we've got to be more specific. We've got to say that you don't, and EASL guidelines, ARSL guidelines, I think are very clear that you do not use liver function tests to discount liver disease of any description. You must go further than that. So if we're only using blood biomarkers, then we're missing a vast population, as we know.
Let me just kind of expand on what I was saying earlier that might take this a little further than where we've been in the past. So if you were just to apply something simple like Fib4, and Louise, your point about reducing the rate of referrals using that is an accurate reflection of what's happening in the UK, having talked to several of my colleagues there. And to some degree, it's happening in the US as well. But one area where you could use that potentially effectively is, let's say you're an endocrinology clinic and you're seeing a bunch of diabetics. Well, that's a high-risk population. So you could take a score. It doesn't have to be the Fib4. It could be the NAFLD fibrosis score. It could be the Ns4. By the way, I didn't mention what's in Ns4. It's alpha-2 macroglobulin, a microRNA called miR34, HbA1c, so a measure of glucose levels, so hemoglobin A1c, and then YKL40. Those 4 markers make up Ns4. You could take any one of these that have a low cutoff and a high cutoff, particularly the ones I mentioned. So Ns4, NAFLD fibrosis score, Fib4. And if the patient that is high risk, such as a diabetic, is lower than the low cutoff, then you can feel confident that that patient, while they have risk factors, is certainly not at risk for liver disease right now and can be deferred in their evaluation. If they're above that low cutoff, then that patient needs something else done, either a sequential test with what we'll talk about in a moment, an imaging study, or maybe a second blood-based biomarker test, or you could just refer that patient to a hepatologist and let them move forward with their own evaluation. And then obviously, if you're at the high range, that's easy because those patients get referred on anyway. So it makes it very simple. If you're dealing with a high-risk population, so maybe let's just tell if you're listening and you're an endocrinologist, you're a primary care doctor, you can apply those 3 tests very simply to a diabetic population. And if you're lower than the lower limit, for Fib4, it's 1.3, then you're good. If you're higher than that limit, they need another test, either another blood test or an imaging study or a referral to a hepatologist. So I think that gets us beyond where we were 50 years ago. At least it gives us another benchmark to achieve. It's not certainly the end-all be-all. It does identify patients that would otherwise not be diagnosed because either their liver enzymes aren't hitting a red flag, or they're not complaining of a symptom, or the primary care doctor just doesn't have time to focus in on fatty liver today. They did the simple test, simple blood test. They could get that answer and then refer them on if it's abnormal.
So Sunil, noting that what you do for a living is you oversee the commercialization of Ns4 for GenFit, is there anything else to say about how they're being used beyond what Stephen and Louise have been talking about in terms of the value they can bring?
Many of the important points have been discussed, but I'll try to bring them together and try to integrate into for example, my thinking of the space. First and foremost, fully appreciate the point from a patient perspective that time has gone on, yet we're still not completely there. I think that one thing that will greatly help, there's many factors that influence that. There's economic factors that influence that. There's obviously test performance characteristics that influence that, and sophistication of guidelines that influence that. But if we just take that last one as a major catalyst that we believe is going to be influencing how we approach this moving forward, if you really dig into, and we take the NICE guidelines aside for a second, they're very unique in that regard, and we say, what do AASLD and EASL guidelines kind of look like? They provide context, but they don't go that last step in providing kind of the granular details that are necessary to implement a screening strategy or use of test 1, 2, 3, 4 to finally get at that evaluation. And I think it's very important, right? So if a guideline says use Fib4, use XYZ to identify patients, but doesn't really provide the guidance as to how, which cutoffs to use and in which sequence, and more importantly, what data supports that algorithm. I think that's the thing that that Stephen alluded to, which is, all about validation and bringing a bigger data set to bear to inform on what's that right strategy. I think that's the missing piece that's going to really, move the needle, because when it comes to taking the good preliminary data and then moving that one step forward into the clinic, it's all about clinical utility. And in order to really define that, we're talking about how does that testing paradigm influence clinical behavior. And I think, for example, as someone in that field, we're committed to doing that. We're committed to funding that, and because it's an endeavor. It's an endeavor, and it takes a while to generate that evidence. But once you have that evidence, you can look at a health system. You can show this kind of flow chart of how patients move in the system as a result of various testing strategies, and what does that mean? What does it mean to them? What does it mean to the healthcare system? What does it mean to the overall cost that's bore on those patients? So I think that's very important. I'll just make a very small comment: is Ns4 is available through LabCorp and Covance, but that's just for clinical trials and research. We haven't finalized a deal to move it into the clinic just yet, but we're working very, very hard on that, and we hope to have an announcement on that fairly soon. But just wanted to caveat that.
So thanks, everybody. So we've talked about liquid biopsy, right? The other meaningful source of data without biopsy would be the kinds of imaging devices that are available. And historically, those tend to be things that are either very expensive, MR, a little bit cumbersome or bulky to manage, FibroScan, and costly. But one of the areas that we're seeing development is in the creation of lower cost, high quality imaging devices of different kinds. And Sunil, as the second piece of where data is likely to be generated in new ways, I'd like you to spend a little bit of time, if you could, just talking about some of those, what's coming up and where it's coming from.
No problem. I think it's a very exciting time, and I think there's a lot of things fueling this. And we think about the revolution of what's happening from a mobile computing standpoint. Cell phones essentially far more powerful than supercomputers of a few decades ago. And of course, at a very, very low power consumption. This really enables really, really interesting things. And I think with 5G, I think this is going to be taken to a new level. I would say, just taking a step back to put it into reference, an MRI, and by the way, I'm not vilifying the MRI. I think it's a phenomenal tool and it's done wonders for medicine. But generally speaking, whenever you say 1 Tesla, 2 Tesla, 3 Tesla MRI systems, each Tesla costs about $1 million. So just to put it into perspective. And it's unfair to suggest that a smaller system or a point of care system exactly matches and outperforms an MRI. I don't think it's intended to do that. However, if it can get closer, either through innovations on a hardware standpoint or innovations on a software standpoint, that's tremendous value to the healthcare system, to the patient who now may not need to book and wait for time on the scanner, which is certainly an issue that we're hearing about with COVID, for example, and there's kind of delays in getting access to some of these systems. But nevertheless, this democratizes the technology and provides better insights to triage, to identify, and bring some of that power back to the clinician, the healthcare provider at the clinic, ultimately empowering the patient. So if I had to describe some of these kind of developments, we can kind of put them on 2 axes, some that are more on the software side of innovation and some that are more on the hardware side of innovation. I'll start with hardware. As you know, there's been a movement towards miniaturization and going point of care, and ultrasounds have kind of slowly been doing this over the last several years, decades, in fact. The classic trade-off has always been around quality. As you go to a point of care system that runs off a battery, it's a low power system, can you get the same fidelity as a large system? Generally, the answer in the past has been no. But with some of these innovations that are occurring by smaller companies, so I'll give you a few examples of Sonic Insights. eSonics is another example of kind of point of care butterfly network. These type of systems that miniaturize the system, but yet keeping a very high fidelity scan. Now you're not really making as much of a compromise as going to a full out radiology system. And through software, they're able to do all kinds of unique implementations to extract features and information about tissue function. In some cases, even looking at heat. For example, caloric output. And there's a company called Endra that's doing kind of work on this axis more from a software perspective. And I think what that's doing is it's taking some of those features that normally would have been in a large MRI type facility and democratizing them down into a point of care system, and taking into account ease of use. And I say that because that is a linchpin for this field, where you can make things smaller, but you may not make them easy to use. And so there's a lot of smart software that has to go in on the back end to ensure that you're getting the right measurement, you're looking at the right organ, and that this technology is easily scalable, trainable, and things of that nature.
Stephen?
Where we're headed is definitely in that direction. We need to be able to go to the patient, make it easy for the patient to get tested, rather than them having to seek out, get in their car, look up a place to go, wait in a long line, find a time that's convenient for them that matches the convenience of the imaging center. That's the way we do it today, or that's the way we've historically done it. Just think back to, you have belly pain, you want to get you go see your doctor, he orders an MRI or a CT scan or a right upper quadrant ultrasound. You leave the doctor, you go to the scheduler, they book you an appointment, then you have to go. Sometimes you have to take a prep, sometimes you have to have an IV put in, and you get contrast, plus or minus. And then you get the study, and then you have to wait a while for the results, sometimes up to a week for the radiologist to read it, send the report to the primary care or the referring doctor that ordered it, and then they have to call you and go over the results. And often that's done by a physician extender, not even the doctor necessarily that ordered the test. It could have been a medical assistant that's helping the physician as well. So if you have questions about it, Sometimes you have to leave those questions and then the doc finally gets back to you, or you wait until you see the doctor in clinic to go over the results. Having said all that, we need to get better at that if we're going to address Louise's concern of finding these people with their asymptomatic disease but have high risk or have already developed advanced liver disease and just don't know it. And so that brings in these point of care tests, if you will, these handheld devices, these minimal footprint devices that can go into the clinic or that can sit in the corner of a clinic and be pulled out, and a result can be provided within a matter of minutes to the patient. It's non-invasive, it's easy to use, it's easy to interpret, and you get a result. Now, that result doesn't necessarily have to be as detailed or quantifiable as a fancy MRI test, but it needs to give us a ballpark. Does the patient have fatty liver? I don't need to know how much fatty liver. Does the patient have fatty liver? Does the patient have at-risk amounts of fibrosis? I don't need to know if it's an F2, if it's an F3, or if it's really even an F4. I just need to know that that patient has some degree of scar tissue that warrants further evaluation because they are now deemed moderate or advanced, meaning essentially F2 or greater. I don't even need to know if there's underlying NASH present. I'm happy knowing there's fat and there's some degree of fibrosis, because you don't get fibrosis without inflammation. That's all part of the wound healing response to injury. So if a point of care test can provide that for me, I think that's great. And I think that takes us to the next level, the next step, if you will. Now we can provide a simple blood-based test. We can marry it with a simple point of care imaging test, and we can get pretty darn close to where we need to be on who should be referred for further evaluation and who should be just told, lose weight and exercise, come back and see me in 6 months.
Fundamentally, what you're describing is a better system, basically to weed out of the system people who don't need additional testing or care, so that we can do a better job of using time and resources to focus on folks who do need more care. Is that kind of where all that comes together?
Yeah, I mean, again, if you just take for simple math, 100 million Americans have fatty liver, and really we think by most accounts only about 25 million of those, that's a huge number, so I don't want to downplay that, but 25 million of the 100 million are at risk of disease progression. Then if we have a test that can exclude the 75 million that we don't need to worry about today, doesn't mean we won't ever have to worry about them. We can talk about that another day about when we need to do follow-up testing. But today, when they're in my clinic, if I have a test that can exclude 75, 80 million of them, that's the 75, 80% solution right there. And then we can hone in on those that have a positive test. And that's where we still need better diagnostics, is getting at the people that are at risk and defining with some degree of fidelity how severe their disease is without sticking a needle in their liver.
Which we'll get to in a minute. Louise, how does that line up for you with what you do right now with TAWS and FibroScan? And how would this make your work easier or just enable more people to get care in ways that are helpful to them?
I think Stephen makes an excellent point there, and it's one of the reasons that Towers and Health was created. As you know, the medical healthcare is all about the few, the actual few that got the test that was abnormal, the actual few that were picked up by the GPs to send to secondary care. And I think by targeting with non-invasive technologies, the new devices coming, as is discussed earlier, but FibroScan, and I use FibroScan predominantly because it's the one that's most researched. It's the one that's biopsy proven. It's the one that's available now. And as we know, in the next couple of months, it's only going to get more accurate with the release of new systems, which will bring it more in line with higher quantification, higher quality for the cap, higher quality for the kilopascals. So it's only getting better. But Stephen makes one absolutely great point in the context of why should this be healthcare? A lot of people go to the gym and make significant changes to their lifestyle because they know their lifestyle problem. If I was a dietitian today, I would not be doing weight loss or dietetics without a FibroScan, or an equivalent device, handheld, able to be used. If you're going to advise somebody on diet, weight, and to plan that management, we know that you want to be able to prove and watch that change in behavior. Stephen said a couple of weeks ago that the average engagement is about 3 months. One of the advantages of these new devices and the smaller technology is they're highly repeatable. But if we take FibroScan, people say it's an expensive test. Well, so is a lot of tests when we get to hospital, because certainly in the UK, we go through a fee-paying system at each stage. Every GP assessment has a cost. Every specialist referral has a cost. A gastroenterologist is slightly cheaper than a hepatologist, but to actually get access to FibroScan costs the NHS and every CCG, who are the clinical care commissioning groups for the GPs, around about £500 to £700 per patient. So there is no surprise that this technology is held upstream. So you've got to pick up a patient by a blood test, probably Fib4, ELF, or one of the ones we've discussed, to get access to a FibroScan. Actually, if you FibroScan or use these non-invasive technologies earlier in the time point, you won't miss the person who is going to have the normal Fib4 or ELF or AST ratio. So what you're using is a funnel system. The more people who get access to it further down the stream, the cheaper this system becomes. And therefore it becomes more cost effective to be able to do that, which is one reason that Towerson Health was created. I can go around and people and our operatives can go around any GP surgery at minimal cost to that pathway, and it doesn't matter what device is being used. In some respect, it's about patient engagement. Blood tests and liquid tests do not engage patients. Being able to sit there with the patient in front of you, and that's one of the reasons that I'm engaged very heavily with FibroScan, because in 35 years of dealing with liver patients or alcohol dependency or any drug dependency, the actual engagement you get from the patient, whether it is a child, to the mother, to the father, their engagement and their change is quite dramatic. If you follow up every month or every 3 months, particularly if you've got them on a timeline, you keep that engagement and you can say, did you change something or did you not change something? And I think I would never give a patient a result back that I'm following up in FibroScan until I say, what have you been doing for the last 3 months? And it is very, very rare that somebody will tell me that I made a change and I don't see an improvement. The other option is the 9 out of 10 patients who do change aren't the problem. It's the 1 or 2 out of 10 who don't change, that if you catch them at that 3 months and say, yeah, I can see you didn't make that change, then that's really important, because it's like, oops, they reconfigure and they rethink about that whole process. I've got a great example. I had a gentleman who changed jobs and he started to work into a hotel. And I did his FibroScan and literally it was, oh my God, what have you done? And he said he now started eating fast food every single day because it was easier. But his liver had gone to really quite fat, well, very fatty from relatively normal to a high stiffness score, which obviously doesn't necessarily equate with fibrosis, but it does, with the liver function tests, highly indicate that he had a highly inflamed liver. But you can see it quite rapidly. And there is a lot of doubt out there as to whether or not serial readings with FibroScan can be predictive or not predictive. But I think that's down to the user. I think that's down to the quality of the scan and the IQR. And that's going to be the same in any device. The more devices we can get at a local level, the cheaper the whole system becomes and the less we're going to miss people. Because liver cancer is the second largest cancer in the world. It is diagnosed so late that only 1 in 10 patients survives more than 5 years. Despite all of the discussion that we're having today about these techniques, it is still for the few that have actually been diagnosed, not the ones who we need to get out there. So if I was a Jim, if I was Jenny Craig, if I was Weight Watchers over here, if I am putting in a weight loss program, I would be wanting to know and add to my system something that can show those people that they can still carry on losing weight, get fit, and actually reverse liver health. Because you look at heart diets, it's not about the heart. The heart's a muscle. It's about improving your internal metabolism, your liver health. Diabetes diets, again, it's not about the diabetes, it's about the improvement of the liver health, but we're not testing for it. So everybody's targeting diet and improvement. Nobody's measuring it except in blood markers. And I think what we miss then is that ability to keep a patient on track. And if we can keep the ones who can be kept on track and really get that motivation, then we're left with the ones that are harder to treat, the real behavioral changes, the ones that are too far down that pathway that we might need bariatric surgery for. And I think I wasn't part of the discussion last week, but I thought it was a really engaging session. And I think if we look at what the FDA was asking for, which were clinical endpoints, if we look back with fat in the liver, we know cardiovascular risk increases with simple steatosis. But we're not looking for it because we're targeting drugs at F3 and F4 just before cancer. And it is a sad shame that patients weren't involved in the discussion about with the FDA, because people will now be diagnosed with cancer because we can't give them a drug that could reduce or slow that process down while we wait for this. We've seen it in hepatitis C. We saw a great turnaround in mortality, transplant costs, donors being needed, because we treated the sickest hepatitis patients first with the all orals. So we have the evidence that if we can actually change the end pathways for liver disease, we can still have great outcomes. But while Intercept and other drug companies now accumulate that data of how many less days those patients spent in hospital, how many times they less visited the GP, how much more time they spent at work for these endpoints, people will die or develop liver cancer. And I think, agreeing completely with Stephen, we need a combined effort throughout the country and all countries that these devices shouldn't necessarily be only medical, because they are going to be so useful to every gym, particularly if you're on steroids, you've got an inflamed liver, but you look really healthy on the outside. But actually, what are you doing internally? And that's why I engage with FibroScan. That's why we developed Towers and Health, to make this cheaper to doctors, to primary care, to hospitals, to allow all sorts of patients into clinical trials, for example. But I heard a very good webinar by Prospectum last week, and a lot was said about why FibroScan shouldn't be used in comparison to Multiscan. FibroScan is not a direct competitor to Multiscan. But if you're going to find the patients you need to put through Multiscan, FibroScan is going to find the mass. Multiscan's not going to do it. So there's a combination of all of these devices and wet markers and AI, which we're going to go on to help patients, but find more. But it doesn't just have to be in a medical world. We don't isolate gyms for that.
So, quickly, first of all, duly noted, Louise, since the first time you came on, you've been asking the question, isn't who should we test and who should we not test? Implication being we should test everybody or virtually everybody. Are we yet at the point where we have digital biomarkers that come out of machine equipment or will come out of the next generation? I guess you mentioned Endrasonic, Insight, eSonic, the others. Will we be able to create some kind of digital markers from there that people can use to gauge their health, or are those devices not precise enough to do that?
I think so. I think, in fact, as I talk to some of the founders and some of the people in that space, they refer to that as physical biomarkers. So it is yet a biomarker, and there's many different combinations that you can create, you can find, you can identify, leveraging the next topic as well, which is AI, machine learning, vision, as well, to kind of extract those features. So I think the answer is yes. It'll take a little bit of time to develop the evidence for that. To all the points that were just discussed, I think the big benefit of some of these new technologies is the cost, right? And I think that is an elephant in the room. If you have a $100,000 piece of equipment, you're fundamentally limited to where you could put it, unless there's someone paying for that, or there's a kind of a direct kind of like cost payback period, I think it's very prohibitive for a lot of clinicians, clinics, and even professional groups, including dietitians and stuff like that, at least from some of the discussions that I've had, at least, behind closed doors. The interest is there. I think as some of these innovations come out, the cost comes down, more of the things are enabled. I think it can lead to that world that we just described.
So thanks, Neil. Let me follow up with one thought, and then I want to go on to AI because we're going to run out of time quickly. So what Louise is describing is what I guess I describe sometimes on the podcast as the wellness paradigm, which is helping people be well. When you talk to physicians sometimes, they say, well, I only use a test once a year, and why would I do it more than that? Because the liver doesn't recover all that quickly, and drugs don't work all that fast. But if the purpose is to help the patient guide her or his own health, then things that we can test more often to give people data that say you're on the right track, you're on the wrong track, what track do you want to be on, and then work with them on how to get there. Stephen talked about the smile phenomenon, that people do their best at 3 months and they start to come back up. What I think we learned from the wellness sources is that if we work on behavior and we provide data more frequently, then we have a better chance, far more cost effectively than in the healthcare system, of helping patients figure out ways that they can drive and improve their own health using steps that they're willing to take rather than those that are imposed on. Just an editorial comment. Any thoughts on that?
I'll jump in just really quick. I think that's spot on. I think of that in a larger context of gamification, the gamification of healthcare in many ways. And I think about just my Apple Watch. Not that I'm promoting the Apple Watch. I get zero incentive from Apple, but just as a discussion topic, if you have one of those, you see the rings, and intuitively if that day you were healthy, you've been mobile, you've been doing stuff, if you were active or not. It's very different, at least to me, when I see the rings and they're not even remotely closed. And I know I've been super lazy that day. I mean, there's an incentive to get on the bike, do something. I got 3 hours left in the day. What can I get done? Going up the stairs a little bit, anything. And I think that's kind of where we're talking about in terms of patient engagement and these sort of, whatever you want to call it, blood-based, imaging-based, whatever the case may be. But these data points and these quantifications that can provide additional guidance and evidence to help us lead the better version of our own lives. I think that's super important.
You say Apple, I say Samsung, same idea. You're absolutely right. It's not the product, it's the general approach to the idea of wearables that I think matters more. Stephen, do you have anything to add before we jump into AI?
I think those points are all very valid, and I agree with them 100%. We know in clinical trials, the more frequent visits we make with our patients, the higher the probability that they're going to do what we ask them to do. And essentially, whatever device you have, a Fitbit, an Apple Watch, whatever, becomes that reminder. And it absolutely is true. It just makes me feel bad, though, every time when I look at mine and I don't do what it tells me I'm supposed to do, and I don't have the time to go do it. So I just feel bad about it. But it is helpful to some people.
Well, I know what your workouts look like 5 days a week. I'm not really worried about you personally.
I do have one comment coming back with Sunil, and I totally agree with Sunil, is the fact that with the Perspectum study recently with the UK Biobank, if we are really saying that 10% liver fat doubles your rate of risk of severe COVID and admission to hospital, then bringing this more to the fore where these devices are utilised throughout, that additional motivation. We haven't learned the lessons from the previous sort of MERS, SARS and H1N1, but maybe this time it is the opportunity where liver health is given a seat at the table for most of the comorbid conditions that are there, and monitoring everybody within health, bringing it more to the fore, makes it more affordable, and everybody should be having one. Every patient in every GP's practice should have had some form of liver assessment, and the more practical it is and the physical is, the more it engages a patient.
So, Louise, one of the things I think we're going to talk about here within the next few weeks goes to that, which is what is the level of proof that you wind up needing around this link between viral pandemic and fatty liver before society will mobilize in the way that it can when it really believes in something and doesn't until then?
The only thing I was going to say was something my husband said the other day, that if in 10 years' time we hit another pandemic and have scanned and liver assessed everybody for fat and targeted the diabetes, the cardiovascular, the metabolic syndrome that this is all part of, and we get 100 million people healthier, we could have saved each country several £100 billion. That's exactly where we sit now. If we don't do it, we're back bailing countries out in hundreds of billions of pounds. Or do we invest in health as a real serious going concern, particularly in countries with rapidly rising NAFLD and NASH? China, 29% of Chinese now have NAFLD, but those are the Chinese in the big cities that are more westernized. So it's a growing concern, but the question, I suppose, is anybody going to take any notice? Because we stigmatize the liver. We don't talk about it enough in any comorbid condition. It's not looked for in any guidelines unless it's a liver-related guideline. So if the medical world itself stigmatizes talking about the liver, how is the patient supposed to know, or any individual to know, that their liver really is one of the key organs in any disease process?
Well, so I'll add to that one of the things I think we're learning in the States this year is that people would like to deny the potential to get sick until they absolutely can't deny it anymore. And part of the role of integrated leadership is to lead people to do better in situations like that. So part of my question becomes, at what point do you gain the momentum to get people who previously have looked at liver one way to start to look at it differently so that we can accomplish what you're talking about? I don't think it's an easy top-down sell. I think actually the UK and the US, and how the two countries that handled COVID both proved it's not an easy top-down sell unless leadership is willing to do things that are difficult and unpopular in pursuit of health. Save that for another day, but that is a real challenge there, which is how do you build the social momentum to actually do it? There are at least 3 good systems right now that are being developed and starting to be promulgated and used for AI of the liver: Path AI, HistoIndex, Reveal Biosciences, and maybe more. I don't mean to leave anybody out. Instead of talking about the nuance of the differences between the systems, I want to talk about why they matter. And really, they matter for 2 reasons. First of all, as we've discussed a few times on this podcast, and Stephen has an article soon to be published on this subject, one of the real problems with biopsy is actually reading the results. There are many special things about biopsy. It is the cleanest way to figure out level of fibrosis. And fibrosis isn't simply about how much collagen you have, but it's about the architecture and the form of the collagen within the liver. Sunil commented to me offline the other day that when you look at ballooning cells, you see structures, capillary structures start to form around that, also architectural, that suggest potential for more serious liver disease pretty quickly. So the ability to see a slice of liver gives us the ability not only to add things up and count them, but also to identify architectural patterns that could be precursors of something bad being about to happen. Problems are, to the naked eye, those things are amazing. The architectural patterns are hard to find. And that using the scoring methods that we've got right now, we have tremendous variability in terms of what happens when 2 people read a biopsy slide, or even the same person reads the same slide 12 months apart, depending upon the variable. Correlation between the 2 readings is never higher than about 0.8, frequently as low as 0.5. And in marketing research, if we did that with our clients, I get fired. So it means 2 things. Number one is it means, as we discussed, we can't really tell how good a lot of medications are simply at resolving issues of fibrosis, because we don't know the degree to which the signal is getting drowned in the noise of sloppy reading, number one. The second issue, which may in some ways even be more important than the first, is what happens if you try to predict these results. What most of us are taught at some point in life, even before we get out of high school, is that you have some variable, it's something called an independent variable and a dependent variable. And the goal of analysis is to figure out in some way, shape, or form, what is it that makes the dependent variable change? The question might be, so what can we really do to reduce fibrosis? How much of it is about different elements of a NASH score? How much of it is about other factors? What are the thresholds at which things become easier to do? For that to be right, you can either have been a hepatologist who's been treating patients for dozens of years, tens of years, or a lot of years, and seen enough patients that you intuitively know what the patterns are. So when Stephen talks about cirrhosis being reversible until you see portal damage, that's quantitative, but that's also a result of what Stephen's been treating for the last 20 years or whatever. But the rest of it then becomes, can I quantitate that? And if you've got tremendous error around your dependent variable, then fundamentally you're trying to predict something really sloppy. And prediction is sloppy in the first place. So until we can tighten up our dependent variable measures, until we can be more consistent about knowing what we're trying to predict, all the other tools that we're talking about, better tests, better imaging, will be limited, maybe more precise in telling us where we sit, but limited in terms of telling us what that means and what's the most important thing to do next, because we don't have a dependent variable measure that makes sense. I felt for the longest time that AI becomes a pivotal piece of this puzzle, whatever technology you use, because it really is the piece that will enable us to start to not only do a better job of identifying individual patients, but taking the aggregations of data that we're talking about and laying them up against ultimate end results in the liver. We can do that right now with outcomes in other places. But outcomes in cardiovascular take, as Brian pointed out last week, tens of thousands of patients and maybe 20 years to sort out. Well, if you've got liver disease, you don't have 20 years to get this sorted out. You don't even have 2 years to get this sorted out, right? So AI becomes a pivotal element in doing that. I don't think we need to take time today and talk about what exactly it is makes for good AI or bad AI. All the AI that's out there is good enough to make a significant difference, I believe. And with that, comments, questions, thoughts? Stephen?
As I alluded to in the last podcast, how do we improve the imperfect gold standard until we get to a non-invasive new standard? And if you look at the data that's been generated with AI off of liver biopsies, it's made, and this has all been done in the context of therapeutic drug development in the field of NASH. At least my familiarity with it has been that way. And each one of those, each time it's been studied, juxtaposed against semi-quantitative analysis, fully quantitative analysis using artificial intelligence has always provided a much more granular, detailed analysis of whether or not a drug was effective or not effective relative to fibrosis predominantly. And I think that we need to really focus on putting effort into developing that and augmenting the semi-quantitative analysis that pathologists do. I'm not saying replace pathologists, but we can augment and come alongside and have a companion diagnostic that basically just expands on what they've shown. And until we can get to a non-invasive test, I think we have to really exploit that AI that's out there.
I agree with that fully, Stephen. I also wonder whether if we had more confidence in the quality of the biopsy data that we get, whether in clinical trials or not, and that would be provided by better liquid testing and better image testing, we can actually start to draw some conclusions that we can't now in advance of a perfect non-invasive test or robust enough non-invasive tests, or even to help push us further down that path by telling us where it's a good place to look more and where it's not so good a place to look more. Does that follow?
It does, but even more specifically, we are learning about the pathogenesis of the disease even more so by applying AI. Now we know, for instance, that in certain zones of the liver where steatosis regresses, that's also, interestingly, where fibrosis regresses, where collagen bands begin to shrink and perivenular and pericellular fibrosis begins to dissipate. And as we learn more about measuring and assessing ballooning degeneration, can we one day get to the point where we can say it's not a matter of going from some ballooning to no ballooning, but what if you go from large clustering of balloon cells to maybe spotty balloon cells? Does that relate to long-term outcome? Maybe. What if we went from 60% ballooning to 20% ballooning? That's something that can potentially be measured by AI, but can't be assessed semi-quantitatively by a pathologist's eye. Maybe that can then be linked to outcomes. Maybe it can be linked to fibrosis, which is linked to an outcome. But I think we have got to get better with the tools that are out there right now and utilizing them to help us find data that is reproducible time in and time out and is not subjected to this inter and intra-observer variability that plagues what we do today and is making it challenging for the agency to accept a surrogate endpoint, in my opinion.
Okay, so I completely agree with that. And I was only going to add one more thought based on what you just said, and then Sunil and Louise comment, and then we'll exit. If we were able to identify a region of the liver where reducing steatosis leads to reduction of collagen, and we then had a handheld imaging device that could say as much as 5 or 10% of the liver in a series of scans that could be targeted, You would then be able to translate that biopsy knowledge into real-time on-the-ground diagnostics. The pieces are there to do that, or will be coming to do that. And at that point, I think I totally agree with what you say. That's how we get to accelerated approvals, because we really know what matters. But we also then can put a device like that in Louise's hands or in Tawa's hands and go out and start looking at patients wholesale and figure out where is the risk really at a level far more significant and far easier to evaluate than anything we have right now. I think that's where all this winds up coming together. Everything we're talking about today comes together, where you can combine AI, which gives you a much better sense of where the target is or what you want we're trying to do, with better blood tests and better imaging that make it clearer how you can do that. And in the case of imaging, for less money, so you can put it in the hands of more people. That would be a great direction, I think, to go in. And that's my last thought for the day. Sunil, Louise, Stephen, any closing comments?
Just picking up from what you and Stephen were both saying there, I think we do have to take into consideration when patients donate samples, whether it's for clinical trials or to have their diagnosis confirmed, these are very valuable assets. And if we can use AI to make the best judgment of those donated samples to get the best results, then AI and any future technology has to be used, because if you are really going to convince a patient to have a liver biopsy, which they really don't want, then it is our obligation to make sure that we get the best accurate information out of that small sample that they are kind enough to donate at significant risk at times. And I think by keeping advancing the technology, then we are doing patients a great service by really trying to take this beyond a physical needle that takes what we consider a gold standard, and we've discussed for a lot of times here, isn't the gold standard. Radiology biopsies, for example, are smaller than percutaneous biopsies performed by physicians, so you get more tissue on one than the other. And I think it is absolutely vital that we protect the integrity of every sample that a patient is kind enough to donate, particularly in clinical trials. And going back to the FDA's change of heart, that undermines the samples that those patients gave if they are questioning the data that was taken. And again, we have an obligation to make sure that that is as robust as possible within the techniques that we've got now without moving the goalposts. So that would be my comment. It's really to protect these. They're absolutely vital samples that they're kind enough to give.
Thank you. Stephen, Sunil.
I love this topic. I think it's fascinating. I think it's going to uncover all kinds of wealth of information. I mean, for anybody who's listening, who's seen the slide, a pathology slide of any tissue, of any part of the body, you know, you'll see thousands of features. I mean, we talk about 4 features whenever we talk about NASH. We talk about steatosis, inflammation, ballooning, fibrosis. There's thousands, right? So even the configuration, like Roger, to your point, the architecture of how these things are laid out and how they change over time. I think short answer is I think this approach is going to shed light not only on the disease, it's also going to potentially give us information that's going to lead to better drug development, maybe even better compound selection as well, when you kind of being able to uncover how these things work. And I think the approach is not purely a pathology approach. I think, the same, to be honest with you, a similar approach was used by us to identify, Ns4 just as an example. And, what's interesting to your comment around blood vessels and stuff, of many other things, microRNA 34A is an oncogene, it's a suppressor. So as disease goes up and you see this marker begin to go up, the reason for increased risk of HCC, it's not so decoupled from the rest of these processes. And I think having these type of hypothesis-free approaches where you're digging into the data, you're grabbing valuable insights, blood-based, pathology-based, maybe even imaging-based, actually, to be honest with you, I think they're gonna be really remarkable and transform our understanding of the space. Of course, that will ultimately lead to better value and options for patients that are based on unique science. And I think that's what we're missing, is we're kind of missing additional color and insights coming so that we can learn as a field. And I think this is the right approach.
Thanks, Stephen.
I don't have anything additional to add. That's good.
Good. And that's a first. So congratulations, everybody. Stephen, for that assessment, and everyone, and all 4 of us for putting it on the table to the point where you get to that place. That ends today's episode. I want to thank the surfers, Stephen, Louise, Sunil, who were able to join us today. Once more, we talked about a lot of stuff today that should make patients interested and curious, and providers and advocates and developers and everyone else send questions, send comments. We'd like to start to engage more often with people who have simple questions we can answer, complex questions we can answer, or would like to come on and talk with us about some of the perspectives they have about this podcast or any of the others. Special thanks to engineer and podcaster Frank Sacco, who makes us sound so good, social media master Eric Rounds, who makes our stuff go around, and our editor and general social media support person, Ellen Charap, who has been making this stuff work better. And an extra special thanks to you, our subscribers and listeners, who've made us the fastest growing fatty liver podcast in the world. As we close, as we always do, what surprised you today? Louise, why don't you go first?
I suppose what surprised me is how we've come so far with blood tests and these devices, but how far we still have to come, given the rate of diagnosis. And I think that still surprises me.
Okay. Stephen?
I agree. It is surprising that it has taken this long to come up with a non-invasive solution to identifying patients at risk for disease. And I think it speaks to the heterogeneity of this disease and the challenges that exist in identifying these patients, because it's not a one-size-fits-all. It's a very complicated disease with very different presentations in different ethnic groups and different populations around the world. So it is challenging, but we have come a long way, and I'm looking forward to the next steps that we're taking over the coming days, weeks, and years.
Thank you, Sunil.
I am surprised that from a drug development standpoint, there isn't more, at least even discussion of companion diagnostics or complementary diagnostics or something to refine that kind of development strategy. And especially in light of this news coming from the complete response letter, maybe that'll change the field's thinking.
I guess what surprises me is I see this chasm. On the one side, I see that we are within a year, 2 years of having cost-effective, non-invasive testing that will allow us to provide patients with information they can use to drive their own health better. And on the other side of the chasm, we are waiting for different kinds of numbers from a disease paradigm that doesn't work as well. And given the heterogeneity of the disease, we don't know exactly what to say on the disease, on the illness side. My hope is that we can figure out how to bridge that chasm, how to understand that imperfect information will still help patients take much better care of themselves if given to them properly and supported properly, and that these tools will at the same time enable us to start pouring into the heterogeneity of the disease and understand it better. I want to thank you guys. I think it's been a spectacularly interesting session. Every time we get to the end of one of these, I'm surprised by how much I've learned and how interesting it's been. We will be back on Thursday, July 16th with episode 14. Don't know what it will be yet, but I'm guessing it will either have to deal with patient empowerment or selecting winners and losers in some shape or form. Until then, everybody, stay safe. That may take a lot of work depending on where you live in the world, but stay safe. Surf on. We'll see you next week.
You've been listening to Surfing the NASH Tsunami. Send in your questions to surfingnash.com, and our panelists will spend the first 5 minutes of next week's episode answering your questions. Visit us online today, surfingnash.com.